Okay, well, good afternoon, good evening, everyone, and good morning to some people as well. It gives me great pleasure to welcome today Dr. Abhik Mukherjee, a colleague of mine from the Pathological Society. He works in the University of Nottingham, and I've known him for at least 10 to 15 years. So, Dr. Mukherjee trained in medicine in India. He initially trained in radiation oncology in Calcutta University and did a MSc and PhD in oncology at the University of Nottingham. But then he saw the light and trained in histopathology in Leicester and Nottingham. So he's got a very strong clinical and histopathological background. Um, he was a National Institute of Health Research academic clinical fellow and lecturer, and he is now associate professor and honorary consultant at Nottingham University and Nottingham University Hospitals. His research interests have been in the molecular characterization of lymphovascular invasion, both in low-grade breast cancer and also in GI cancers. And he also has a background of research in biomarkers in inflammatory bowel disease. Multiple projects that he's been involved in nationally and internationally, and also a very strong publication record. Don't want to take any more of his time, but he's going to talk today on inflammatory diseases of the colon and rectum. I think in a lot of these talks, there's a lot more focus on cancer biology and cancer pathology. So it's really good today that we've got balance back into inflammatory conditions of the lower GI tract. So without further ado, I'll pass over to yourself, Abhik, and thank you very much for your time and input to this program.
Thanks, Richard, for the very kind introduction and for inviting me to deliver this educational talk. And I got an invite for gastrointestinal pathology, and I was in two minds of whether doing cancer or inflammatory, but I chose to go down the inflammatory route today, though I would be very happy to discuss cancer pathology at a later session if we schedule one. So today I'm going to talk about inflammatory diseases and specifically those of the colon and rectum. So without much ado, I will start on with the case one. So this was a 57-year-old female. The patient had known ulcerative colitis, had rectal bleeding, and this is a biopsy from the sigmoid. And while we still encourage people to send us a series of colonic biopsies in IBD cases, and we always prefer that, we still sometimes get single site biopsies. And here is what we got. And what I usually do is I look at the low power view in such cases. And here there are, as you can see, that we can see that the inflammatory gradient is altered in these two biopsies. It looks quite blue at low power. Going higher, you can see that it's pretty inflamed, and going even higher, you start looking at the inflammatory infiltrate, and there's a bit of mild crypt distortion. But what mainly we can see, it's a very dense inflammatory infiltrate and mostly of chronic inflammatory cells, lymphocytes. And if you go further in, you can see that there are some focal areas of formation of early cryptitis and crypt abscesses, and lots of plasma cells as well, expanding the lamina propria. So this is a case of more chronic inflammation than acute inflammation, and that fits in with the chronic history of ulcerative colitis which we had in this patient, and we were happy to sign this out as ulcerative colitis. And one of the key indicators of ulcerative colitis, apart from the active inflammation, the cryptitis, the crypt abscesses, and the goblet cell depletion, is the basal plasmacytosis. It's one of the earliest histological features of IBD and one of the best predictors of IBD, as we have found in our clinical practice. And the plasma cells usually are at the base of the mucosa, but in IBD there is a loss of the plasma cell gradient, and you can find it expanding the whole of the mucosa. Now, the basal plasma cells may be really normal, for example, in cecum and ascending colon, where you can get a lot of basal plasma cells. So always ask yourself, where am I getting this biopsy from? And the plasma cells, as you know, they have that eccentric nucleus with abundant cytoplasm looking like a fried egg with sunny side up. And the other feature which crypt distortion in chronic cases, or ordinarily should look like test tubes, either longitudinally or in transverse sections. But when the crypts are distorted, they no longer look formally like the longitudinal test tubes. The villiform appearance of the mucosal surface and the wide crypt mouths are also another indicator of chronicity in ulcerative colitis. And you can get Paneth cell metaplasia. So these cells, which have very rich in the granules due to the mitochondrial content, etc., and they are more abundant in the right colon, and we consider it significant only if it's distal to the splenic flexure. It happens more in IBD than in non-IBD cases, but it also may occur in other chronic colitides. So remember that these are indicators, but they are not specific to IBD themselves. So with that, we'll move on to the other IBD common example that we get is a case of Crohn's in this case. And this was a 35-year-old with acute abdominal pain. And here is a whole mount section because the patient had a surgery. And as you can see, even at this power, there is blue, and this blue is in the form of lymphoid aggregates in the mucosa. But not only in the mucosa, these lymphoid follicles are going transmucosally into the submucosa through the muscularis to the subserosa. So there is a transmucosal distribution of the lymphoid aggregates. The lymphoid aggregates are forming germinal centers. But in other areas, there are histiocytic collections spaced between them. And as you can see that these lymphoid aggregates have gone into the submucosa, you can see them beside the submucosal vessels. There is expansion and fibrosis. Mucosa, another common feature we see in Crohn's, that's just showing intramuscular and subserosal lymphoid aggregates as well. There is a transmural chronic inflammatory infiltrate spreading apart the muscle fibers of the muscularis, all classic features described in Crohn's, but also you're getting these lymphoid aggregates with small histiocytic collections being seen within the lymphoid aggregates. So Crohn's granulomas, you can get granulomas anywhere. You can get them in the mucosa, submucosa, but also within lymphoid aggregates in any of those regions that we are talking about. And the Crohn's granulomas, as you see there, that's an example of a mucosal granuloma sitting just below the surface epithelium on the top panel. It's well circumscribed. There is no necrosis, but Crohn's granulomas can be small and subtle, and they can form horseshoe-shaped giant cells. And as in the previous example, there can be subtle granulomas within the lymphoid aggregates themselves. But they've got fewer multinucleate cells than non-Crohn's disease. So granulomas often help us to delineate whether it's a Crohn's or an ulcerative colitis. But we should always remember the context of granulomas and where these granulomas are located. Sometimes we see granulomatous inflammation secondary to the rupture of a crypt. And these cryptolytic granulomas are not specific. They may happen in Crohn's, they may happen in UC, they happen in infectious disease, they happen in diverticular colitis, diversion, drug-induced. So it's not a if you see a cryptolytic granuloma where the crypt is breaking down due to its infection and abscess formation, it's a less discriminant for Crohn's disease than a non-cryptolytic granuloma. So non-cryptolytic granuloma in the right context would be more in fitting with Crohn's colitis than with ulcerative colitis or other diseases. But again, we get regularly a certain proportion of cases in which we cannot classify the IBD based on the biopsy material that we have. And we use the term IBD unclassified only for our biopsy reports. And we use the term indeterminate colitis only for resections. So that's the practice here in the UK. We do not write indeterminate colitis for biopsy samples. We just say IBD unclassified. It's a holding diagnosis because we've often seen that in the subsequent biopsy, the case may either diverge into an ulcerative colitis or into a Crohn's colitis by further information coming through, by further sites being sampled, and therefore a better understanding of the disease. It can often happen in early disease when you do not get pointers for one or the other. It's also put in as a diagnosis when the clinical history doesn't match with the histopathology and there is a mismatch between the clinical history and the endoscopic report and the histopathology. For example, they've seen strictures in certain parts of the colon and you're seeing just some inflammation and you're seeing it more like, say, UC, but there aren't any granulomas, but this is not matching. So you hold the diagnosis and query because ultimately the diagnosis is a combination of the clinical, endoscopic, and the biopsy report. Sometimes when you get insufficient histopathological material, for example, sufficient number of sites are not sampled, and sometimes in a colonic a rectal biopsy or a terminal ileal biopsy due to constraints of access of sample, etc. And as you know, both of those sites, the sample is quite important in a colonic series. For example, for the rectal sparing, we tend to see in Crohn's, and the terminal ileal involvement we see in Crohn's. But sometimes terminal ileal involvement may occur in a case of backwash ileitis, in a case of ulcerative colitis as well. So we have to take the whole case into context. So if we see mixed or unusual histopathological features, for example, if we see a pancolitis with rectal involvement, but some granulomas sticking around in different places, if there are mixed features, we may prefer a diagnosis of IBD unclassified. But remember, in pediatric cases, you can see rectal involvement of IBD. And so we necessarily don't put those cases as IBD unclassified if it's in the pediatric age group and the endoscopy and the clinical history is in keeping with Crohn's disease. So overall, this classification, the IBD unclassified, indicates that there is a presence of an IBD which needs further follow-up, but it avoids labeling the patient with the subtype. If the mucosa is inflamed and there are histological features, we favor IBD, or if there aren't, we don't favor the IBD. So IBD may be definite or very likely. And then we go for classification, ulcerative colitis favored over Crohn's, or the other end, Crohn's definite or Crohn's favored, and in the middle, we've got the IBDU. Now, what is also very important to remember that in cases of IBD cases, we also have to look whether there are dysplastic changes, because that's one of the risks of IBD, because if it becomes dysplastic, there is an enhanced and galloping pathway of developing high-grade dysplasia and therefore subsequent cancers. Therefore, we have to be vigilant about dysplasia development in IBD. So the very often we are sent a series, and the query that is sent for clinicians because they see something unusual is this UC associated dysplasia, or is this a sporadic adenoma? And first thing I do is to check whether the abnormality is within a zone of the inflammatory bowel disease, and are there mixtures of dysplastic and non-dysplastic crypts. So biopsies of the surrounding area. So when you communicate to your clinical colleagues and they are asking you this question, you may convey to the CPC meeting that you want to see the biopsy from the surrounding area to be absolutely looking for field changes. And visible and localized lesions may be amenable to endoscopic resection. And there are variations of IBD dysplasia, yes? So you get the classical dysplasia in which you see the stratification, the nuclear abnormalities, etc. And these are very often confirmed by P53 positivity. So sporadic adenoma would not be positive for P53, whereas an IBD-associated dysplasia would be preferentially positive for P53. And the converse would show for the BCL2 staining, though we found in our center the BCL2 stain to be less discriminatory and less interpretable in some cases. But overall, the literature would suggest that BCL2 would be more positive in the sporadic lesions rather than in the IBD-associated dysplasia. But you can get various sorts of dysplasia. You can get a hypermucinous gastric foveolar type dysplasia. You can get crypt dysplasia, and those crypts at the bottom would be strongly positive for P53. But you can also get a goblet cell depleted dysplasia, as well as a serrated adenoma-like dysplasia. So there can be a huge variation of the dysplastic look that you can get in IBD cases. So IBD dysplasia, fortunately, it's only seen in only a small proportion of the cases, and previously dysplasia-associated lesion or mass, we do not call that anymore. We just say this is IBD-associated dysplasia, and this dysplasia may be either visible or by endoscopy or not visible. But sometimes you have to distinguish between UC-associated dysplasia and just reactive regenerative changes from the inflammation itself. And these reactive changes may occur in the context of acute inflammation. And in those cases, there may be evidence of surface maturation. It may sometimes be seen in drug-induced changes. And I always find the P53 immunostain to be quite useful in this pattern. So either coming up with a very strong staining for the P53 or a total negative pattern in the case of IBD dysplasia. So that's where we start our discussion on inflammatory diseases of the large bowel, the two main inflammatory disorders of the large bowel being ulcerative colitis and Crohn's under the umbrella of inflammatory bowel disease. But we have to understand that there are other differentials of inflammatory bowel disease. So inflammatory bowel disease is very much a context-dependent, age-dependent, and clinical history-dependent and endoscopic correlation-dependent diagnosis. So what I would stress to you that please urge your clinicians to write a decent history and always look at the endoscopic reports before you formulate a diagnosis. one of the common things which I tell my registrars, they come with a colonic series, they see patchy inflammation in different parts of the bowel, no granulomas anywhere, and they say, all right, we favor Crohn's disease. And I ask them at that point of time, have you just gone back and looked at whether there are any previous colonic series in these patients? And lo and behold, they find that there has been a series 6 months ahead where it had a pancolitis. So this patient was diagnosed as ulcerative colitis, has received treatment, and now, due to partial treatment response, the inflammation has gone patchy. So don't suddenly change the diagnosis of ulcerative colitis to Crohn's based on patchiness of inflammation in the subsequent biopsies in a patient who's being treated for ulcerative colitis. But there are other differentials for IBD to be considered as well. And here we move on to case 2. Here is a 32-year-old female with the history of diarrhea, and the FIT test, so the fecal immunohistochemical test, was positive, and that led to the patient having a colonoscopy. And as you can see on this colonoscopy, the biopsy appears quite blue at low power. So the inflammatory gradient of the colon, as we know of, which is top heavy near the surface epithelium and peters out as we go towards the bottom, that has changed. And as we go in and see, there is a significant amount of chronic inflammatory infiltrate, lymphocytes, mostly some plasma cells in the lamina propria, but also looking near the surface, a bit of the surface epithelium has stripped off, and the superficial crypts, as we can see, there is a dense pink band just surrounding those surface crypts. Going even further on higher power, you can see a lot of plasma cells. So there can be plasmacytosis, as you can see in ulcerative colitis and other IBDs. But it's this pink, dense, thick band of collagen which we are seeing in this case, which makes us diagnose this as microscopic colitis, and specifically the collagenous colitis variety of microscopic colitis. Just to show an additional case along with this, again, colonic biopsies looking very blue down the microscope at low power. Go in higher power, there's an increase in the chronic inflammatory cell infiltrate in the lamina propria, but also lymphocytes walking into the crypts, so lymphocytic cryptitis. But more importantly, a lot of these lymphocytes are also into the surface epithelium, so increased intraepithelial lymphocytes as well, that at a higher power, highlighting the blue dots inside the surface epithelium, so intraepithelial lymphocytosis. So that was an example of microscopic colitis of the lymphocytic variety. Reminding you, the normal subepithelial collagenous plate is usually very thin. In collagenous colitis, it becomes a thicker band. Some capillaries may be entrapped in that collagen, and you can use collagen stains, EVG, PSR, etc., to highlight the collagen just below the surface epithelium. The surface epithelium often becomes degenerate. It can strip off, so stripping off of the surface epithelium is quite common. Basal plasmacytosis, which we often look in IBD, may be as common in microscopic colitis, and so can Paneth cell metaplasia occur in 44%. Just having active inflammation doesn't change the diagnosis to collagenous colitis with isolated cryptitis, etc. It still remains collagenous colitis. But we should always be aware that there is an increased incidence of inflammatory bowel disease developing in the context of microscopic colitis, ulcerative colitis more so than Crohn's disease. So sometimes when the patient is very symptomatic, having fit test positive, etc., I may write a note, because usually microscopic colitis has no endoscopic features and has no signs and symptoms, just watery diarrhea, with no endoscopic say endoscopy saying absolutely normal. The fit tests are usually negative, but if I see that it's a fit test positive and the patient has got some symptoms, I may put a line saying that this is looking like microscopic colitis, but please keep the patient on follow-up, because a certain proportion of microscopic colitis may evolve into IBD, and therefore the patient is best kept on a closer surveillance loop. Moving, and here is the next case. So this is a 71-year-old male who had previous prostate cancer and is now experiencing rectal bleeding. So what's going on in this case? And here we have got some biopsies. These biopsies don't look as blue as the previous ones, so not as much of inflammation as we can make out from these biopsy fragments. But what we have is, I can see easily the crypts not being longitudinal flask-like, so the crypts are distorted, and the lamina propria is expanded. And if I go closer, I see that it's expanded by fibrosis. Now, in the context of previous prostate cancer and rectal bleeding, we went and looked at the history. So that was, this patient had been treated with radiation for his prostate cancer, and that helped us make the connection that this could be radiation proctitis, obviously in 71-year-old with fibrous splaying between the muscularis. You could also think about prolapse, etc. But radiation can induce prolapse-like changes. Other clues for radiation proctitis would be eosinophils, which may be producing eosinophilic cryptitis or eosinophilic crypt abscesses. And in chronic cases, distortion of the crypts with a mild chronic inflammatory infiltrate. There can be mild epithelial atypia and fibrosis, but also in chronic radiation disease, you can get atypical fibroblasts, which are very hyperchromatic, have stellate extensions, and they are usually more common in the submucosa than in the mucosa, therefore may not be seen on mucosal biopsies. There can be vascular changes, again, commoner in the submucosal vessels, and you can see the vessels can be thick-walled. There can be intimal thickening. There can be fibrinoid degeneration and thrombus formation. The endothelial cells may also have atypia, not just fibroblasts. And you can get hyalinization of the bigger blood vessels with obliteration in cases of radiation disease. There can be mucin depletion like ulcerative colitis, but it is the context. It is the fibrosis, vascular changes, and atypical fibroblasts which help us make the diagnosis. Sometimes we may struggle with an atypical fibroblast versus a cytomegalovirus infected cell. I would always throw in an immunostain for a cytomegalovirus in these cases to be absolutely sure of what I'm dealing with. But as you can see, chronic radiation colitis therefore may mimic IBD in terms of crypt distortion, mild inflammation and basal plasma cells, and some sort of fibrosis between the crypts. So it is context, context, and context, which I can't emphasize enough when we come to inflammatory pathology. So another case, known Crohn's and still having rectal bleeding in a 56-year-old female. And this patient, as you can see, it looks blue. The biopsy is looking blue. So the inflammatory gradient is obviously changed in this biopsy. There's a bit more of inflammatory cells from superficial to bottom, though not much of active inflammatory cells or cryptitis or crypt abscesses in this field. There is a little bit of fibrous splaying between the crypts, but what caught my attention at the bottom of one of these fragments is this fuzzy pink round cells, which therefore I can see the ingestion of RBC, and these trophozoites therefore indicate to me that this patient has developed superimposed amoebiasis, and you can see these pale foamy cells with ingested red blood cells. They resemble macrophages, but they are PAS positive and CD68 negative, confirming the amoebiasis. And clinically, it may look like an IBD with segmental involvement. It can also look like a UC in terms of a fulminant picture. So remember, do not miss an infectious colitis like amoebiasis in such cases. Moving on to the next sort of have to keep in mind. So this is a 58-year-old female with a sudden onset of abdominal pain. And this is a resection. And as you can see superficially, the surface epithelium seems to be intact, while there is an inflammation in the submucosal layer, probably going on into the muscle. So let's go and see. There is a huge amount of neutrophils sitting in the submucosa, a little bit into the muscularis, but not so much into the subserosa. And this was a rare case of phlegmonous colitis, which happened in the context of a patient of liver disease with cirrhosis. And the patient had developed this sudden onset abdominal pain presenting to the A&E. This resection of the bowel, in which the surface mucosa was relatively preserved, but with quite necrotic submucosal tissue. Obviously, ischemic colitis was in the top of our differentials in mind, but we did not see any crypt withering, etc., to indicate that this was ischemic colitis, and we had the history of that liver disease accompanying in the clinical notes. Moving on to another important differential, which we often see in cases of inflammatory bowel disease. So here was a case of a 54-year-old female with a history of acute myeloid leukemia previously, and this is what we have. The biopsy initially looking quite innocuous, except for that apoptotic body glaring out of that crypt space. Mild bit of crypt distortion, inflammation, not that much changed out here. And again, going to other multiple fields, the apoptotic bodies in the crypts become more and more apparent, though not very abundant, so occurring at a lower rate, but you can still see the apoptotic bodies within these crypts. And because we have the context of the acute myeloid leukemia provided for in this patient, we diagnose this as a graft versus host disease. And the epithelial crypt cell apoptosis is characteristic. But as you know, you can see occasional apoptotic bodies in other diseases as well. So for a graft versus host disease, it's recommended that you have more than 6 of apoptotic bodies per 10 contiguous crypts. If it's less than that, you can leave it indeterminate for GVHD, but you have to allow treatment based on clinical judgment. So if something like this happens, I will raise the query with my clinical colleagues, and though it doesn't quite meet the apoptotic body counts, that I would be comfortable with to saying that this is definitely GVHD, but given the context, I would raise the suspicion of GVHD if you've got sufficient clinical suspicion for that. But as I'm pointing to you, you can get some crypt abscesses, though it can be less neutrophilic. You can get apoptotic bodies within the crypt itself. But you can also get isolated patches of more inflammation. So without the history, you can often struggle to make that diagnosis, and you may erroneously call it like a chronic colitis and a chronic UC. So you may raise those differentials without knowing the history. This case, again, another important call to make in the context of inflammatory bowel disease. So this is a male aged 18 years who's had abdominal pain and fecal immunohistochemical test positive. And this patient had a history of primary sclerosing cholangitis, which was liver biopsy proven primary sclerosing cholangitis. And he had this subsequent abdominal pain with the FIT test. And here are the biopsies. And the biopsies, you will agree, at low power are looking very, very blue. And these are the right colonic biopsies, looking pretty inflamed. And you can see the increased plasmacytosis, the crypt distortion, some neutrophilic infiltrates scattered around in the lamina propria. But the left colonic biopsies look very normal. Yes, they don't look as inflamed as the right. So what is going on? So this was a predominantly right-sided colitis, which in the context of the primary sclerosing cholangitis was diagnosed as PSC-associated colitis. And PSC-associated colitis, the IBDs which predominantly occur in PSC is either UC. So the IBD phenotype in patients with PSC seems different to classic UC or classic Crohn's. So what we usually see in PSC-associated IBD, there is extensive inflammatory distribution, but the ascending colon is more frequently affected than in UC alone. And parts of the mucosa may be inflammation-free. And there can be signs of active inflammation, which is highest proximally but peters out distally towards the rectum. You can get still high rates of pancolitis, even up to 80%, and low rates of proctitis. Isolated ileal disease would be rare in PSC-associated Crohn's disease, whereas in Crohn's only, this would reach to about 18 to 30%. So remember, PSC-associated colitis, and to make that connection with in the context of the clinical history is immensely important. Another differential of inflammatory bowel disease, and in this case, we had a female 32-year-old with a history of ulcerative colitis who had had a subtotal colectomy, and the patient has been suffering from rectal bleeding. So here is what we saw. So this is from the rectal stump biopsy, and it's very blue, very much looks like lymphoid aggregates. Going ahead, it's full and full of lymphoid aggregates. Some crypt distortion is present. Very focally, there was a little bit of active inflammation seen. And you can see how dense the lymphoid aggregates and lymphoid inflammation is. Here is another focus of isolated active cryptitis, which was seen in this case. And this is a classic example of diversion colitis occurring in the stump due to the diversion of the short chain fatty acids due to the operative procedures which have been undertaken and the diversion, so the fecal stream having been diverted. So this creates inflammatory changes in the stump itself and is an important differential. And just for having that foci of active inflammation doesn't change the diagnosis. Sometimes it's very difficult, and we often get class as saying that this is around the stoma. Is this Crohn's? Is this diversion? And all you see is chronic inflammation. And sometimes you do not see chronic inflammation and you see active inflammation. And I always write a descriptive diagnosis of what I see in that case and leave it to the clinicians to make the call. Yes, because I do not see endoscopically if they've taken it from a pouch and pouch, is it pouchitis or is it not pouchitis? I make the clinicians and the endoscopists give that definitive call at the CPC meeting, and I provide the descriptive, unless of course I'm seeing frank non-cryptolytic granulomas, etc., which point that there is active Crohn's disease at that site. Just based on active inflammation sitting there alone, I do not tend to call it either Crohn's or definite pouchitis. I say that this is large bowel mucosa showing active chronic inflammation, no granulomas seen, and I leave it for the clinical pathological discussion at my CPC meeting. So diversion proctocolitis, it's an inflammation of the excluded segment of the bowel, and the histology may show diffuse chronic inflammation, lymphoid hyperplasia, and ulcers, but also, as I said, may have the cryptitis and crypt abscesses. Last but not the least, a very, very important differential to always keep in mind, yes, male abdominal pain, rectal bleeding, and here is a rectal sigmoid biopsy, looks very blue, the inflammatory gradient is all altered, and it looks to have inflammation, it looks to have crypt abscesses, etc. And it's looking very much what would be quite compatible with an IBD. And then you look at the endoscopic report and you see that there is a lot of diverticular disease in this patient. So remember, diverticular colitis. So diverticulitis is very, very important in the differentials of IBD. And the mucosal inflammation can be near the diverticular, very sigmoid heavy, but confusion with IBD histology arises because of the basal plasmacytosis, the Paneth cell metaplasia, and the active inflammation in terms of cryptitis and crypt abscesses. But it is that correlation call that you have to make in this patient to give and favor the diagnosis of diverticulitis. Before I end today, I will briefly talk about drug-induced colitis, and drug-induced colitis is getting more and more important as a differentials of IBD. And in this case, we had an elderly patient with watery diarrhea. The TTG, so duodenal biopsy was taken, showed villus atrophy, but the TTG was negative. The T cell receptor changes were negative. And here is the colonic biopsy, very blue, and showing more lymphocytic cryptitis and intraepithelial lymphocytosis. Again, very dominant chronic inflammatory infiltrate with patches of intraepithelial lymphocytes, and this patient was taking the antihypertensive olmesartan, which is an ACE inhibitor, and it has been shown to be associated with the sprue-like enteropathy, and it can create histological features quite similar to celiac disease or tropical sprue or Crohn's, yes. So you can see villus atrophy in the duodenum, but you can see a very much a lymphocytic colitis or intraepithelial lymphocytosis with flattening of the surface villi in the small intestine, etc. in this type of drug-induced colitis. The other category which I'm seeing more and more, because the PD-1, PD-L1 agents are being used more and more, and associated with that, we are seeing a lot of checkpoint inhibitor-induced colitis, and it's all very important to look at what history the clinician has provided. Diarrhea, fulminant diarrhea in a case of a malignant melanoma, and though they have not explicitly stated that this is treatment induced with previous history of melanoma, lung cancer, etc., always to go back to the clinical notes of the patient to check the history, because clinicians often forget to provide the history. And the look can be one of various patterns. It can look like an active colitis with neutrophils, a neutrophilic infiltrate. It can look very IBD-like. It can look microscopic colitis-like, and it can look both like a lymphocytic or a collagenous colitis, or it with apoptotic bodies in the crypts, or it may look with crypt withering, etc., looking like an ischemic colitis. So any sort of look is possible with drug-induced colitides. So remember this important differential and look for subtle clues in the clinical history. So if I summarize about inflammatory bowel disease and its pathology in the bowel, it's all about collating all the information that you have. So histology is a very important part. But what does the imaging say? What does the endoscopy say? What are the clinical signs and symptoms? Collate it all and then come to the differential. And clinical features are not an optional extra in this context. We have to insist on the clinical details to come to a correct diagnosis. I will end my talk there, and I'm happy to take any queries.
Thank you very much, Abhik. That was really excellent. We've already got a question straight off the mark from Mars. Can we use collagenous colitis and microscopic colitis interchangeably?
I do not do that because collagenous colitis will have so microscopic colitis can be either collagenous, in which there is a thick band of collagen present, in which I will say this is microscopic colitis of the collagenous variety. So I will put my diagnosis as collagenous colitis. If I don't see a collagen band and just see the lymphocytic gradient altered, I will say this is microscopic colitis of lymphocytic colitis variety, and say lymphocytic colitis as my bottom line. Sometimes when I see patchy collagen thickening, but also in other areas and in other fragments which are full of just lymphocytes, I see mixed collagenous lymphocytic colitis pattern of microscopic colitis. So I have said that on occasion. But I usually try to define what variety I am seeing.
Okay, thank you. Are there any other questions from the audience? So you emphasized the gradient of the lymphocytic infiltrates quite a few times. Are
Yes.
there any real kind of hard and fast rules, or not hard and fast, but kind of guidelines that you can use about the
The,
gradient being top to bottom or bottom to top that are helpful?
there are no hard and fast rules, but this is what you're generally taught when you're starting off as a registrar in histopathology. Look at the colon. If you see a few lymphocytes, do not think that it's chronic colitis. They are usually more nearer the top surface down than at the bottom of the crypts. It fizzles out as you go towards the bottom. But if you see a uniformity of that inflammatory gradient from top to bottom, you certainly have an increased inflammatory gradient. And it's the reverse, I think, for the duodenum, where you get more at the bottom and less at the top. So
Right.
these are initial observations.
So we've got two more questions. Any scale to grade the activity of E. Crohn? I'm not quite sure I understand that question.
Okay, so there are various scoring systems for IBDs
Yeah.
and their activities, but we as a center, we do not do that because it's so subjective and variable from one person to other. we tend to just describe what we see, whether there is crypt distortion, whether there is goblet cell depletion, whether there is Paneth cell metaplasia, whether the chronic inflammatory cell infiltrate is mild, moderate, and severely dense, and then describe the active inflammation, active cryptitis, crypt abscesses, and the presence or absence of granulomas. So I would usually not do the scoring.
Okay. Um,
And there's a question of the pediatric Crohn's. Yes. So pediatric Crohn's, the pediatric types of IBD. So classically, we are taught that Crohn's disease usually spares the rectum. And ulcerative colitis is a pancolitis which involves the rectum. But in cases of PEDS IBD, and I do a PEDS IBD clinic with the pediatricians as well, and in those cases, the presence of inflammation in the rectum does not exclude the diagnosis of Crohn's disease, and we do not make it ulcerative colitis or IBDU just based on the presence of inflammation in the rectum. If everything else, the endoscopy, the fibrotic strictures, the patchiness of the inflammation, etc., are pointing towards Crohn's disease, even if the rectum is inflamed, we will say it is Crohn's disease.
okay.
In terms of cryptitis and crypt abscesses are usually defined by the presence of neutrophils. And if, for example, in microscopic colitis of the lymphocytic variety, I see lymphocytes going into the crypts, I say explicitly that this is lymphocytic cryptitis. Or if there are excess of eosinophils, I will say that there is eosinophilic cryptitis and eosinophilic crypt abscesses. And then in a case of an eosinophilic gastroenteritis, I will prefer the differentials of infection, including parasites, drugs, and other allergic diseases. And I will also say IBD on certain instances can present as a predominantly eosinophilic infiltrate. So please consider that in your differentials.
Okay, thank you. Are there any
I
other?
haven't seen plasma cells to be invading into crypts, so I don't think I've seen plasma cell cryptitis.
Okay. Probably not so much for the. It's probably more a case for the small bowel, but how often do you see, a lymphoid aggregate that turns out to be either a low or high grade lymphoma in the bowel? I mean, high grade is probably relatively straightforward, but low grade lymphoma in the large bowel, obviously it's more common in the small bowel. Do you ever see that as a confusing element?
If I see a very diffuse monomorphic population of lymphoid cells, yes, as you say, high-grade lymphomas are more occurring in the large bowel, and those are easier to pick up. But if I see a very diffuse low-grade monomorphic infiltrate and with destruction of crypts, etc., I will pass it through my hematology colleagues before putting out a diagnosis. I always ask for a second opinion. And sometimes you will see that the case has been referred from the hematologist with a query of a low-grade lymphoma. So in those cases, I do not start doing an immunohistochemical panel myself. I usually refer the case to my hematology colleagues, so that because it's a small sample, you do not want to be wasting cuts of tissue and deplete it. So it's all the immunos done at the same time, which is more useful than ordering one or two and then sending it off, and then it's all vanished because cuts have been taken.
Yeah. Okay, thank you. So what are the features of Crohn's in the ileum from Tocker?
Okay, but so Crohn's in the ileum Tocker are no different from Crohn's affecting the other parts of the bowel. So you would see obviously patchy inflammation, you can see crypt distortion, you can see cryptitis, crypt abscesses, you can see granulomas, you can see fibrosis. And one very useful features I often find is thickening of both the muscularis mucosae, expansion of the submucosa with fibrosis, and also expansion of any muscular layer. So in resections, those become very useful parameters as well. You see, it is difficult in the ileum because of the natural lymphoid aggregates and pairs patches which are present in the terminal ileum, especially to make a definitive call just from the lymphoid rosary. But if you see it going transmucosally and transmurally, obviously it points more towards being part of the Crohn's rather than being part of the normal anatomy.
Okay. Thank you. Are there any further questions? There's a lot of questions we've had, which is really gratifying. It shows that I think your talk has stimulated a lot of interest. And I think that your emphasis on, the clinical features, which you emphasized again and again and again, and with good examples of how you could get the diagnosis wrong if you just thought down one line or another, has been very, very useful. So these are recorded and they are available to the delegates afterwards. Got a vote of thanks from a few people there. Thank you very much for your time, Abhik. An absolutely excellent talk. Ava will be in touch in due course with an attendance certificate which indicates the attendance for your record. We're very grateful to have you back at some other point in the future, of course, though we've got people signed up to the end of this academic year, but we may be calling on you next academic year if that's okay.
That's absolutely fine, and I can do a different topic then.
Yeah. And for the rest of the audience, just to say thank you very much for your continued involvement and interest. Please share the link generously with your colleagues wherever you are. The attendee numbers are growing each week and each month. Thank you, of course, to Ava and Diagnexia for their continued support of this program. Next week, it won't be me. It'll be Professor Ming Du, who is a hematopathologist working in Cambridge. Again, another long-term colleague of mine through the Pathological Society. He'll be talking about molecular testing in lymphoma. I know that in many territories that might not be immediately relevant, but Ming Du has got a background of training in China, and he does have experience of translating testing to lower resourced areas. So I think it will be of great interest to all of you. So please attend next week. Same time on Wednesday, whichever territory you are in. Thank you very much, Abhik. I'll let you get back to your afternoon in sunny Nottingham. It's sunny in Manchester here as well.
It is sunny here today as well.
That's quite unusual. Yeah. Thank you very much, Ava, for your continued support and Diagnexia's support of the program.
And thanks, Richard and Ava, both.
Okay, thank you.